So first we have Kate Kelly, a postdoctoral fellow with the University of Prince Edward Island, and she will be presenting on understanding prevailing views of the COVID-19 vaccine 2 years later, province-wide survey in Prince Edward Island. Thank you, Kate.
Hi, everyone. Can you see my slide? Okay.
We can see you.
So hi, my name is Kate Kelly, and as Lauren mentioned, I'm a postdoctoral fellow at the University of Prince Edward Island. I have brown hair, and today I've chosen to wear it down, and I'm wearing a black sleeveless dress. On the screen is a slide consisting of our poster presentation. This poster describes the development of a province-wide survey in Prince Edward Island that aims to identify the factors involved in Islanders' decision to get vaccinated or vaccinate their children against COVID-19, which is outlined in the text box on the top right-hand corner of the slide. This survey represents phase 2 of a larger 3-phase study that aims to provide evidence-based support to PEI families about the COVID-19 vaccine funded by the Public Health Agency of Canada. The left side of the slide shows a flowchart progression of how we developed the survey. We began this process with the creation of an advisory committee that consisted of knowledgeable stakeholders in the province, including representatives from the Chief Public Health Office, Department of Health and Wellness, and the University of PEI. We met with this committee 4 times during the development and piloting of the survey. Questions from the survey drew upon previously validated surveys published by established health authorities, such as the World Health Organization and Statistics Canada. In some cases, questions were updated to match the current COVID-19 situation, for example, related to changing mandates and recommendations. Accessibility and equity considerations are briefly outlined in the second box on the right side of the slide. The survey went through 3 iterations before we consulted with an expert in health literacy. Although we used items from previous surveys, the wording of some of these questions scored too high on an objective measure of readability, specifically using the Flesch-Kinnaid grade level tool. The first version of the survey scored at a grade 10 reading level, whereas the average literacy level on PEI is estimated to be around grade 5. So we worked with an editor to make the survey and related documents, including the letter of information and consent form, accessible from a literacy standpoint. We then consulted with the PEI Immigrant and Refugee Services Association to determine language accessibility requirements. This organization suggested that we make the survey available in 5 languages to cast the widest net across the PEI population. These were English, French, Vietnamese, Arabic, and Mandarin. We worked with local translators to translate and pilot test the survey and related material. We chose Qualtrics to host our survey due to its easy-to-use interface and optimization for desktop and mobile users. The platform is compatible with screen readers and provides optimal visual accessibility with regards to a focus indicator and high contrast between elements. The website automatically sets the language of the survey to the participant's default web browser if it's one of those 5 that we had translated, but participants were also able to toggle between the languages using a drop-down menu on every page. Participants that completed the survey were invited to enter a draw for one of 4 $100 Walmart gift cards by entering their email into a separate survey link. And this was done to protect the anonymity of participants. We chose the Walmart gift card as it allows for both in-person or online shopping without the requirement of a credit card. And Walmart also has a wide range of items, including groceries. An important limitation of the study is that the survey is web-based, which may restrict access for some Islanders, and this was a caveat of balancing anonymity with ethical compliance. The final text box on our slide describes our recruitment strategy. We recruited participants through a social media campaign using Facebook and through our project partner, the Chances Family Center. We also contacted individuals from within the community to act as ambassadors for the project. Specifically, individuals across the province were provided with recruitment cards that had a link and a QR code to the survey. We also even had multiple childcare centers that distributed cards directly to parents. And finally, the survey was emailed to over 50 community organizations to share with their constituents, and as well as online via social media. The survey launched at the end of April and will actually close tomorrow on Friday. So although I don't have final results to share with you yet, I can say that just under 2,000 individuals have completed the survey across the 3 counties in PEI. Findings from the survey will be used to determine concerns that islanders have about the COVID-19 vaccine. And this includes those who are vaccine hesitant or firmly opposed to the vaccine for themselves, but it also includes those who may have been vaccinated and have reservations about vaccinating their children. So this information will be used to tailor materials for a program called the Island Vaccine Support Program, which will provide evidence-based information using motivational interviewing and in consideration of cultural safety about the COVID-19 vaccine directly to island families. Our program aims to provide a transferable curriculum that addresses specific concerns related to the uptake of the COVID-19 vaccine and not limited to the province of PEI. Thank you.
Thank you very much, Kate. That was a great presentation. And as a reminder, if you have any questions, please put them in the Q&A box on Whova. Next, we have Sarah Scrutton with the Nova Scotia Health Authority sharing her research entitled Investigating Variations in Survival Rates for Women Diagnosed with Ovarian Cancer in Nova Scotia.
I'm just trying to share my slides here. Okay, so can you guys see the slides or all my notes?
We can.
Okay, so I did put my poster into slides just so that it's easier for everyone to see, but my name is Sarah Scruton. I've got my hair in a bun and I'm wearing glasses and a dark gray sweater. And today I'm going to be presenting my thesis topic, which is titled, titled Investigating Variations in Survival Rates for Women Diagnosed with Ovarian Cancer in Nova Scotia. So the reason why we're doing this research is because sorry, I'm getting feedback here. Can anyone else hear that?
Not on my end, but just as a reminder for those not presenting to mute.
Okay, it might just be my computer. Just give me one sec. I'm just gonna mute. Okay, all right, I'll try that again. Okay, so the reason why we're doing this research is because international research projects have shown that ovarian cancer survival differs both between countries and within countries, including Canada. So this graph here shows 3-year survival for advanced stage disease within some Canadian provinces. And so Alberta has the highest survival at around 38%, and Nova Scotia has the lowest at around 31%. And no one has yet been able to figure out why due to a lack of research in this area. Many factors that explain variations for other cancer types do not apply to ovarian cancer, and the small amount of research that has been done on this topic for ovarian cancer has never been done in Canada. So we've decided to start to try and answer this question on why survival varies in this country, starting with Nova Scotia by looking at how or if different need, non-need, and equity factors vary throughout the 9 former health authority zones shown here on a map of Nova Scotia, and seeing if they explain geographical variations in survival. So first, I'll give a little overview on the difference between need, non-need, and equity factors. So a need-based factor is something that is known to and should directly impact an individual's chances at survival, such as stage. Non-need factors, on the other hand, are factors that should not influence an individual's chances at survival, such as where they're treated. And then non-need factors can also be further categorized into equity stratifiers, which are often demographic variables that should not affect survival, but relate to equitable access to care. So in the case of Nova Scotia, we're also hypothesizing that these differences in survival are not related to the quality of treatment received, but instead they're due to access-related variables. And this is because the size of Nova Scotia means that we only have one specialist hospital where all of the gyno-oncologists in this province work. And due to the high levels of collaboration, women who enter into this care system will receive very high quality, similar treatment pathways. So the issue then lies in the fact that not every woman will indeed access this hospital for treatment or assessment by a gyno-oncologist, which has been shown to greatly impact their chances at survival. So as a result, we also want to determine how variations in survival as a result of the variations in need, non-need, and equity factors can be mediated by providing equal access to care. And so the objectives of this study are to understand how these factors vary throughout the province, how they explain variations in survival throughout the province, and how equal access to high quality care can mediate these associations. So the study will use a population-based retrospective design of all individuals identified from the Nova Scotia Cancer Registry who were diagnosed with ovarian cancer from 2007 to 2016. And for the sake of time, I won't go over all the variables, but our main outcome variable is survival time. Our need variables include health and disease factors. Our non-need variables include health system factors. And then our equity variables include sociodemographic factors. And then finally, we have our two mediating variables, which are initial surgery at specialist care and having ever been assessed by a gyne-oncologist within 6 months prior to and following diagnosis. So firstly, we will determine the prevalence of all of our variables in the population and determine if there are differences in these factors between each former health authority region. Then we'll use survival estimate techniques to determine if there are differences in survival for these factors. And then we'll use additional survival analyses to break down which factors are explaining variations in survival. So we'll do this by noting any changes in results, especially in the exposure of interest. So for example, if we were to add poverty into the model and notice that one of the region's effect on survival disappears, this would mean that poverty, oh, I can hear something. I don't know what that is. There we go. If we were to add poverty into the model and notice that one of the region's effect on survival disappears, this would mean that poverty is likely higher in that region, and it is actually associated with survival rather than the region itself. So our next step will be to determine how these associations between these factors and survival are mediated by equal access to healthcare. And so to do this, we'll break down the associations through a mediation analysis and determine how access to a gyne-oncologist could impact a person's chances at survival. And then finally, we will repeat this process using treatment at a specialist care center as our mediator to see how this also impacts these associations. And so in the end, we'll have a series of relative risks that will help us to explain which factors impact survival and how they vary throughout the province and cause variations in survival, and also how we can mediate these associations by providing equal access to high quality care. And so we don't have results yet because this study is still in the proposal phase, but we're confident that this study is going to help us to better understand why jurisdictional differences exist for ovarian cancer outcomes, with the ultimate goal of identifying areas to intervene and improve outcomes, particularly for subpopulations within Nova Scotia who have poorer survival. And so we hope that the collaboration with the gyne-oncologists and patient partners here in Nova Scotia will help to improve the interpretation of our findings and support the application of our findings into practice and systems change. We also hope that other provinces will follow suit, and we will soon have a bigger picture to determine exactly why ovarian cancer survival varies throughout the entire country. And thank you everyone for listening.
Thank you, Sarah, for your presentation. Next, we have Kendra Cooling with the Vitalite Health Network presenting her work exploring clinical diversity within an autistic cohort.
Hi, let me just share my screen and get it open up here. So as Lauren mentioned, my name is Kendra Cooling, and I'm a PhD student at Université de Sherbrooke, currently working as a research coordinator with Vitalite. Today, I will be going over the results from the exploration of the clinical diversity within an autistic cohort based on the work done by Caroline Jose and her team, along with the autistic partners that made this project happen. As you may know, autism is a diagnosis classified by social and behavioral discrepancies. And while there are specific criteria to obtain this diagnosis, not everyone with autism has the same health profile and the same health experiences. There are many comorbidities experienced by adults living with autism. And when we compare the prevalence of comorbidities or co-occurring conditions, and I'll use those interchangeably, among autistic adults compared to non-autistic adults, the prevalence is much greater among those living with autism. So this began the exploration of the clinical profiles or the health profiles of adults living with autism. So we collected a cohort of 164 adults living with autism, and we were able to calculate a frequency distribution based on 34 comorbidities reported by this population. And we were able we were able to conduct a latent class analysis and break down the comorbidities per profile among those living with an autistic diagnosis. So you can see this reported in table 1, and I'll highlight the key points as well. So on average, when we looked at the group as a whole, we did find 4 primary co-occurring conditions associated with autism, primarily anxiety, learning disorders, sensory issues, and gastrointestinal disorders. However, this seemed like still a diluted set of co-occurring conditions. So we were able to look at these groups, and we found 6 specific groups of health conditions. The first group was primarily categorized by mood disorders, specifically anxiety and depression. And you'll see as we go through the table, most of the subgroups were experienced a high rate of anxiety, but this group specifically seemed to identify through anxiety and depression disorders. Our second group, which is the largest subgroup that we found, representing 39% of the group, seemed to have a relatively healthy profile. There were no comorbidities that were predominant in this group, indicating that this subcategory was able to live a healthy, moderate lifestyle. Our third group highlighted, along with anxiety, intellectual disabilities, speech language disorders, and sensory issues, which seem to be commonly prevalent among males in this group. And then we have our 3 final groups, 4, 5, and 6, and these groups were interesting because altogether these groups only represented 17% of our total sample. However, they also represented the most complex profiles. You can see by the shading of the blocks, those are the co-occurring conditions that were more severe and more prevalent. And we'll look at those in detail. What you'll see here is that group 4 and 5 were the 2 groups that specifically indicated ADHD or demonstrated ADHD as the primary co-occurring condition along with their autism diagnosis. But if we look at group number 4, along with ADHD, there was high prevalence of PTSD, sensory disorders, and musculoskeletal issues. But if we wanted to look at the other subgroup that had ADHD as a primary co-occurring condition, we also saw depression, OCD, and learning disorders. And the reason why we highlight the differences is that despite the autism diagnosis, despite having high prevalence of ADHD, these 2 subcategories or these 2 subprofiles reflected very different health profiles. And this is important to consider because if we're looking to provide support and treatment to this to these people living with autism, what it looks like for category 4 and what it looks like for category 5 are not necessarily the same. And this is really important to consider. We cannot give everyone with an autism diagnosis the same support and treatment. I would like to spotlight on group number 6 because this was a particularly interesting subcategory. This was 5% of the total group that had the most number of co-occurring conditions. It was primarily women, 67% of women, and the entire sample was only 33%. So most of the women seem to fall in category number 6. They also had the highest or the latest age of diagnosis. So the primary age for diagnosis for autism is between 2 and 5, the preschool and school year age. And these participants indicated that they had an autism diagnosis around mid-30s, mid-40s. So that's really late in life. They also had a high number of somatic health conditions, GI issues, musculoskeletal issues, epilepsy, as well as sleep disorders. So we found that very interesting and it's worth exploring. So my PhD program and my PhD research will be to validate these subcategories, to look specifically into these symptoms and the complex needs, specifically as well barriers to healthcare and access to these services that they need. And of course, and with many thanks to Greta Bauer, I might have to reconsider our inclusion and exclusion criteria for the gender and sex diversity representation there as well. So we're looking forward to exploring this in much more detail in the next wave. And of course, thank you to our sponsors and the autistic partners that were able to help us make this research happen. So thank you very much.
Thank you, Kendra. And finally, we will hear from Luke Dugnan from Dalhousie University on the role of guaranteed income in healthy aging, Canadian public pensions and their associations with objective health measures.
Perfect, thank you so much. Can everyone see my screen? And I'm going to try and put this on presenter view. I have a presentation, there we go. Is that working? All good?
We can see your screen, but we can also see your notes, Luke. I think it was better as it previously was.
The presenter mode, eh? Interesting. I was anticipating on needing.
That's great, Luke.
Okay. I just need to find, all right, we'll go through it. I don't have my notes on me because they were in the presenter mode. So we'll go through it and we'll talk about the results. So hello, everyone. My name is Luke. Luke Dyden. I'm a graduate student at Dalhousie University, and I'm presenting my master's thesis entitled The Role of Guaranteed Income in Healthy Aging, Canadian Public Pensions and Their Association with Objective Health Measures. So universally around the world, low income is predictive of increased mortality, morbidity, and poor health behaviors. So we see this relationship universally, including in Canada today, with about 5% of Canadians live in poverty. So one strong poverty prevention strategy that's been used or has been suggested to be used is that of a guaranteed annual income, where a consistent income is applied or provided to all citizens by the government on a consistent basis. Now, Canada doesn't have a guaranteed annual income, but what we do have is old age security, which is effectively a guaranteed income insofar as it guarantees an income floor to every senior over the age of 65, an income floor of around $19,000. So with that being, with them receiving OAS, it acts as a guaranteed annual income. And this has been shown to previously assist seniors in their health outcomes. So we've seen positive associations between receiving OAS and self-reported health and food security. And so we want to take that a step further and use an objective measure of health, which is allostatic load. So allostatic load refers to the physiological wear and tear on the body in response to environmental stresses and demands. And it's an index of 9 biomarkers that's consistently been associated with low income and also been predictive of poor health outcomes, including mortality and cardiovascular disease and a bunch of other negative health outcomes. So that was the goal of the study. And to achieve this goal, we laid out some methods there. So we first categorized our sample through descriptive statistics, and then we ran some ordered logic regressions to allostatic load being a count variable to associate allostatic load with various financial indicators and income-related variables, an overall concept of financial security. And then we wanted to see how receiving old age security modified the relationship between financial security and allostatic load. And then finally, we ran some quantile regressions just to see for whom the impact of receiving OAS was the greatest. And I'll walk you through a few of my results here. So firstly, we can see here is that by way of descriptive statistics, mean allostatic load was consistently higher in lower income, lower savings groups, along with financially insecure individuals. And these are these negative gradients you can see on the graphs in front of you. These relationships held across the ordered logic regression. So lower total household income, lower home ownership, were all associated with higher allostatic load scores, as was being financially insecure. So then we took this financial security index, and you can see here that the odds ratios are 1.6 and 1.6 times the odds of being having a higher allostatic load relative to financially secure seniors for males, and about 1.54 for females. Statistically significant higher allostatic load when they are financially insecure. And then we showed the interaction effect between this and receiving OAS as your main source of income. And so what we see here are these odds ratios below 1, which suggests that the effect of receiving OAS as their main source of income almost removed the effect of financial insecurity on seniors. And so the combined effect of those who are financially insecure, who were also receiving OAS as their highest income source, was that they had lower allostatic load relative to those who would not. So as you can see, the effect was a little bit stronger in males than in females as well. Now, finally, these were the results of the unconditional quantile regression. And you can see that the coefficients, this graph maps the coefficients here, and you can see that it does have a negative gradient as well, getting further away from 0. And this suggests that the strongest effect, the effect that was furthest away, or the impact furthest away from 0, was seen at the higher end of the distribution. So those with higher allostatic load, financially insecure seniors receiving OAS with higher allostatic load, were seen to have a much lower allostatic load compared to financially insecure seniors who were not receiving allostatic load. So by way of discussion, we were able to show that financial security was more impactful than just income alone in terms of a measure of consumption in seniors. And we also showed that OAS had its strongest impact when it was most meaningful. So the variable we used, OAS as main source of personal income, showed that when OAS is meaningful and it makes a difference, which it would for a lot of financially insecure seniors, this is where we saw the health impacts of OAS on allostatic load. And then the results of that quantile regression that I just showed sort of suggest that the effect of, or the impact of OAS on the allostatic load distribution is to narrow it. So I've kind of put together a couple of figures here. You can imagine this is the distribution, the population distribution of allostatic load. And if these are the worst off financially insecure seniors who benefit the most, then you can imagine that the normal distribution kind of becomes a bit left skewed. And that amounts to a narrowing of the distribution of allostatic load, which is a key tenet of narrowing health inequalities and inequities. So altogether, we suggested that this concept of financial security is improved when seniors receive OAS, and OAS is sort of shown to be not just an economic policy, but a health policy as well. So thanks to Dalhousie University Faculty of Medicine and MSSU by way of funding, and I appreciate being here today. Thank you.
Thank you so much, Luke, and thank you to all our presenters. So Dan Dutton asked a question in the Q&A, and I think Sarah has addressed it. So I'm going to read a quick question from David Anderson, and this is addressed to Kate. So did you use any strategies to get those who chose not to get vaccinated to complete the survey? And are you concerned this group will be underrepresented?
Thank you for your question. We know from the literature that those who tend to be vaccine hesitant or opposed to the vaccine tend to use social media for primarily for information. And so we, with knowing that, did a targeted approach using Facebook's marketing strategy. So we had a marketing campaign that actually ran for the entire 8 weeks on Facebook. And so the survey would appear as a post on anyone who used the website from anywhere within Prince Edward Island, and identified PEI as their location, I guess, on Facebook. And so we had quite a lot of interaction through that. We can see through that strategy that 1,700 individuals interacted with the link, meaning that they clicked it. So we do feel that in that sense, we would capture that side. We actually had, we're a little bit concerned potentially that might be the opposite situation, where we might have an over-representation of those who are more opposed to the vaccine, actually, just because of some sharing that went on through Facebook in that sense. And we had, for example, using Qualtrics, it'll identify entries that might be incorrect. And so, for example, if they came from the same person, and there was one instance where someone's entered quite a few times with, kind of anti-vax rhetoric. And so we were able to identify those and kind of capture them and remove it to keep the integrity of the data. Thank you.
Thank you so much for your response. And thank you to everyone for attending. We now have a presentation with Debbie Martin on the Wabanaki Labrador Indigenous Health Research Network that I encourage you all to attend, but thank you for coming to this session.